Welcome, everybody. We're going to give it just a minute for people to enter the room, and then we'll get started shortly. All right, 30 seconds. All right, let's go ahead and get started. On behalf of myself and Lucia Nappi and Allison Rosen, I'd like to welcome you to our fall AYA committee meeting for SWOG. I'm glad you guys can all be here virtually, and I really hope our next meeting will be in person. We've got what I think will be a really interesting agenda for you today. We will start with some welcome and maybe some introductions. We have a new AYA committee advocate and AYA community advocate, as well as Allison Rosen, the official AYA committee advocate. I'm going to give you an update on AYA breast cancer, which is a topic we haven't talked about in several years in our committee. So we thought that would be interesting. Lucia is going to update us on the S1823 study that you've heard about previously here. And then we have two guest speakers. Eitan Orgel from CHLA is going to talk about an NCTN-wide study that he's developed looking at L-carnitine for the prevention of pegosparaginase-induced hepatopathy in AYAs treated for ALL. And we should have time at the end for some discussion of the collaborative design of AYA trials within the NCTN, which is a topic of enduring interest for all of us. And then Michael Roth, the chair of the COG AYA committee, is going to talk to us about the development of a PRO library that relates to AYAs and can be used in trials throughout the NCTN. There's a committee working on this effort, and already there are studies that are beginning to adopt the suggested battery. So that is very interesting work that's being done. And then we'll have time for some questions and answers and further discussion. First of all, the goals of our committee. So what we do is to promote collaboration within the NCTN cooperative groups. We want to encourage and facilitate the joint design of AYA relevant clinical trials and develop an AYA-focused communication platform for AYA members. This is the website that we've talked to you about before during these meetings, and we'll touch on at the end. We want to encourage medical oncologists to participate in the Responsible Investigator Network, which has really been quite successful. A lot of pediatric institutions are in this network, more than 100 in fact. And the aim is to have a champion on the pediatric side and a champion on the adult side. We're lagging a bit on the adult side, but Kristen O'Dwyer and other medical oncologists who have become the responsible investigator at their institution have expressed real satisfaction with this system. And I think it provides a powerful basis for communication between AYA investigators at various institutions and across the aisle of pediatrics and adult medical oncology. The committee also wants to improve medical and psychosocial outcomes of AYAs with cancer. We want to get more AYAs onto clinical trials by disseminating information about this trial availability throughout SWOG and the NCTN. And to help with this, we can also look at barriers and facilitators to clinical trial enrollment, and that's being done in various ways in SWOG and other places. Also, we've talked in this committee before about toxicity initiatives. John Parentesis showed us some big data that he's working on for AYA-ALL toxicity, and I think that has the potential to grow and give us a lot more information about AYAs. We can also, in this committee, work to improve psychosocial outcomes and promote healthy coping and developmentally appropriate care for AYAs with cancer. There are a lot of possibilities for collaborating within the NCORE network on CCDR research and with survivorship and palliative care committees, among other committees within SWOG. And so as we go through our talks today, and as you go through the meeting this week, I'm hoping that you'll all look for such possible collaborations as you attend your other disease committee meetings, and that you can bring that back to our committee and discuss where we can go in collaboration. Cross-cutting topics like sexual health are of interest to our committee, and again, are a great starting point for collaboration with other committees. And we want to, in the quest to get more AYAs onto clinical trials, I think we should, from time to time, consider clinical program development within the context of our committee, because the more developed the programming is for AYAs in the institutions around the country, the better we'll be able to serve AYAs, including getting them onto clinical trials. So that's something I want to focus on a little bit today, and also going forward within our committee. And again, as we go through the session today and you go through this week, we will think about these opportunities and see which ones you might want to participate in. So first of all, within our AYA committee, we want to circle back around and formalize or reformalize the liaisons with the specific disease committees. Laura Davis has recently been tapped as the AYA committee liaison to the Early Therapeutics Committee, so congratulations, Dr. Davis. And there is a bit of a process which we're going to try to make as easy as possible for you. And so if you're interested in being the disease-specific liaison and already attend other committee meetings within SWOG, this would be super helpful for all concerned, and please let me know. We're also looking for junior faculty members to work on the AYA committee, and this is a great opportunity for mentorship and for a role within SWOG, even for the most junior people. We talked about the RI network, and we are developing a website to connect AYA investigators within the NCTN, and that's something that can use some manpower too as we go forward. Allison Rosen, are you here? And if so, would you like to talk about the new community advocate? All right, she must not be. We can do that later if she pops on. What I'd like to do for the next 20 minutes or so is to talk about the topic of breast cancer in AYA women. I'm hoping that we have some representation from the breast committee here, and whether or not we do specifically, I think that we could all consider ways that we can increase awareness of AYA cancers regardless of our disease expertise. And so a lot of the data I'm going to show to you today are from a paper in JCO Oncology Practice that I published with colleagues several months ago. And it is a review article with a focus on clinical practice, and it's gotten some attention and press, which I think just goes to the point that there aren't really so many of those articles out there. When I've gone to write about this topic, I am generally impressed by how few new articles there are between every time I review the literature. And so I think this is a place where we can all make an impact if we're interested in whatever particular disease we study, and also in AYA, that if you collect the seroepidemiology data, the clinical data, you can really contribute to the literature in a way that no one else may be doing. And I wanted to encourage you guys to think about that as we go through. So what I'd like to talk about are age-specific differences in incidence and prognosis in AYAs compared to older women with cancer, risk factors that are specific to AYA women, other special age-specific issues, clinical management, and in this Journal of Oncology Practice article, Julie Graylow and colleagues wrote a nice editorial in which they created an Atul Gawande-like checklist for caring for AYAs with cancer. And so I think, getting down to the granular nitty-gritty of specific care requirements for this population is very useful, is likely to overlap between diseases, and again, is something we can all think about how to use and how to develop such checklists for AYAs and for other diseases in the future. So first, incidence and prognosis. Breast cancer under the age of 40 accounts for a little over 5% of all breast cancers, and the chance of getting breast cancer by 40 years of age is 1 in 196. That makes it the most common AYA cancer in people diagnosed between the ages of 15 and 39 in the United States. It comprises 15% of all cancer and 30% of cancers in females in that age bracket. In the United States, there's currently about 13,000 cases annually in women under the age of 40 and more than 1,000 deaths, unfortunately. AYA breast cancer occurs worldwide with little geographic variation. In Europe, they have documented in their epidemiology databases that the incidence of AYA breast cancer has been increasing since the 1990s. In America, we have documented such an increase since 2004. And on the left-hand bar here, you see that invasive breast cancer, which is in the solid bar that's blue, is increasing at a little higher rate than all breast cancer. Both of those are statistically significant. And then if you look at this green bar on the right in figure B, you'll see that of the different stages, localized, regional, and distant metastatic disease at diagnosis is by far the greatest area of increase in AYA breast cancer since 2004. And so unfortunately, most of the increase in cancer incidence since 2004 is in that distant group. About 10 years ago, it was published that AYAs have significantly unfavorable biology in their breast tumors compared to older women. They're much more likely to develop the aggressive basal subtype compared to older women. And this is shown in the red bars there, and women under 40 on the left-hand side, with 43% of them having basal subtype tumors. African Americans are more likely as well to get the basal subtype. Luminal A and B is less common in AYAs and relatively more common in older women, and this is, as you know, a more treatable type of cancer. In addition to the tumor biology, AYAs are more likely to present with advanced disease than older women, with 2/3 of AYAs aged 25 to 29 diagnosed with stage 2, 3, or 4 disease. So at least regional and possibly distant metastatic spread, compared to only about 1/3 of women diagnosed at age 40 or over. So in addition to this higher stage at diagnosis among young women, there's worse prognosis. So the vertical black bar divides women under 40 on the left, women over 40 on the right. And you see that for the different stages of disease, with red on the bottom being metastatic disease at diagnosis, with, of course, by far the worst prognosis overall, survival lags behind, particularly in the youngest of AYA women, in comparison to middle-aged women through the age of about 60. And on the very top, you see carcinoma in situ in kind of a light green bar. And you'll note that AYAs are the only age subgroup to have a less than 100% survival with that disease category. This is some data I presented with colleagues in 2013, discussing the increase in distant metastatic disease at diagnosis among AYA women. And you see that this increase, if you look back to the mid-1970s when the SEER database was developed, the increase has affected women above the AYA age range, but not above the age of 50. So it's 49-year-olds and younger, but the increase is by far the fastest, with an average annual percent change being the most positive, with the greatest increase year by year in the youngest women in the database, 25 to 29-year-olds. And in addition to the increase affecting the youngest women, the increase in metastatic breast cancer diagnosis in AYAs is also accelerating over time at a rate that is exponential. So that is very scary. And according to the first data slide that I showed you, it's affecting the entire rate of breast cancer in young women in the United States at this point. Now, the cause for this change is not yet known and is really interesting to consider. The rate of breast cancer that's metastatic at diagnosis has more than tripled since the 1970s, despite a leveling off of the population in the AYA age range since the 1980s in the United States. And so it's way too fast for a genetic change. And therefore, one can hypothesize that it must be related to either a toxic environmental exposure or perhaps a modifiable risk factor related to lifestyle. And so I'll talk a little bit about risk factors and protective factors in the next section. Now, AYAs, of course, are generally an unscreened population unless they have known genetic risk for breast cancer. And so it's not possible to affect a change in the rate of distant disease at diagnosis by changing the mammogram recommendations, because although, of course, these tumors could be detected by mammogram, they're rare enough in the population that it wouldn't make sense to start screening younger women at this point. So generally, people need to be just aware of their breast tumors and of their breast tissue, because most tumors of the breast are found by AYAs themselves, given that they don't have mammograms. And there have been recent recommendations that people not do breast self-exams, put out by the American Cancer Society, et cetera, because data shows that overall, if you look at the population, the self-exam leads to false positives and women getting breast biopsies that turn out to be nothing. But I don't think that there's been a specific look within the AYA age range at that recommendation. So that is one of many things that is an area of research that has not yet been done. So now risk factors. I've divided these into risk factors that affect both younger and older women, and they're an asterisk by risk factors that are present for both younger and older women. And then the ones without the asterisk affect young women preferentially. So a positive family history is a risk factor for everyone to get breast cancer at any age, and is a particularly strong risk factor with a relative risk of 3.2 in AYA women. And there's an increasing list of constitutional mutations associated with high or moderately increased risk of breast cancer, and increasingly young women are getting gene sequencing panels at the time of diagnosis to look for these germline mutations, which is great. Tall stature, interestingly, is a risk factor, as is Black race for AYA breast cancer. Hormonal risk factors that affect both old and younger women are early menarche, older age at first birth, and anovulatory infertility. In young women specifically, there's an increased risk for several months after the delivery of any baby. And there's a increased risk with oral contraceptive use that's particularly profound in BRCA carriers. So it's very important that those people know who they are. It can affect their contraceptive choices. Also, early multiparity, particularly in the African American population, is a risk factor for getting breast cancer. Personal and lifestyle risk factors for all ages: smoking, heavy alcohol intake, radiation to breast tissue, and higher consumption of red meat in smaller studies are risk factors. And in young women specifically, thin body habitus is actually a risk factor for HER2 enriched and basal subtype for bad breast cancer. So that is unlike older women in which obesity is a risk factor for getting breast cancer. However, in young women, there are some more subtle factors that might suggest that lifestyle factors do contribute to breast cancer risk. So significant weight gain after age 18 in smaller studies increases the risk for AYA breast cancer, as does the triad of obesity and high caloric intake and sedentary lifestyle. So like a setup for metabolic syndrome is a risk factor for AYA cancer. There are smaller studies that have also looked at protective factors that are specific for younger women in some cases. So breastfeeding is always known to be protective. Vigorous exercise in the AYA period may be protective against breast cancer. Also, more plants in the diet. They've looked at several different types of vegetables and fruits and found them to be protective: cruciferous vegetables, citrus fruits, tomatoes. I liked this statistic that substituting legumes for one serving of meat daily leads to almost a 20% decreased risk of breast cancer in younger women. High vitamin D intake is protective against breast cancer in young women. Now, with the increase in advanced disease at diagnosis, obesity is a known risk factor for breast cancer, or for advanced breast cancer, both in older and younger women. And in fact, the temporal trend that correlates most closely with the increases that we've seen in distant metastatic disease in young women is the obesity epidemic in the United States. It's complicated by the fact that there's this other finding of thin body habitus being a risk factor for adverse biological features. So it's complicated, but it definitely needs further investigation. And for young women, low socioeconomic status, Black, Hispanic, and Native American ethnicity, and low vitamin D levels at diagnosis are risk factors for advanced disease at the time of diagnosis. Specific issues related to patient age. So women with breast cancer have decreased health-related quality of life compared to age-matched female survivors of other types of cancer. These young women, specifically with breast cancer, report decreased cognitive functioning, more fatigue, more insomnia. And young Blacks are particularly hard hit in terms of decrements in their quality of life. They report lower quality of life, worse physical functioning, and greater fears of dying, more unmet supportive care needs than young whites with breast cancer. So definite disparities by ethnicity that need to be corrected in our healthcare system. Special issues for treating AYAs. The average adult with cancer lives about a decade after their diagnosis, whereas AYAs ideally will live for 40 or 50 years after a diagnosis of cancer. And so infertility and premature menopause are huge issues. GnRH analogs have been well studied in breast cancer compared to other diseases and are a great choice for young women. Bone health is a concern, as in second cancers. And doctors should definitely initiate proactive conversations, we feel, about fertility preservation, sexual health, and also psychological health in order to maximize psychosocial outcomes and kind of reintegration into society after a breast cancer diagnosis. And ideally, subspecialist referrals are present for reproductive endocrinology and sexual health and psych. Sometimes these providers are lacking in the community, which is an ongoing problem, but the AYA should be offered these referrals whenever possible. So I'll talk a little bit about clinical management and refer you to some general knowledge about it and also some things we talked about in the paper. So one thing about young women with breast cancer, and I don't know of any reason for this, but young women are 9 times more likely than older women to have a local recurrence of their breast cancer. And interestingly, that has no effect on disease-free survival or overall survival. So women can opt for whatever type of surgery they prefer. They can have a mastectomy, which used to be the standard, but in fact, radiation and a lumpectomy is also a reasonable option for AYAs. Increasingly, Bilateral mastectomy is being considered and recommended, particularly for people who can have genetic testing and be found to have germline mutations that predispose them to breast cancer prior to their treatment. Chemotherapy is used more often and warranted more often in young compared to older women. It is associated with a 35% reduction in recurrence and a 27% reduction in death among AYA women. It's particularly useful for the basal subtype. Neoadjuvant chemo is the usual choice and can make tumors operable, and can be used in borderline lumpectomy candidates and in locally advanced disease. And interestingly, the use of chemotherapy is more common at specialty centers, which is an indication that young women need to be considered as a special population, and people need special education about AYA breast cancer. And so as a group, it's our job to think about how to share this information, not just with the biggest cancer centers, but throughout the community and throughout the United States. Endocrine therapy for early stage ER positive patients is the norm. Tamoxifen is used, and then ovarian suppression is recommended for the youngest women and also for premenopausal women receiving chemo. In the Journal of Oncology Practice paper, my clinician colleagues made the point that it's not really useful to follow the NCCN guidelines for AYAs and say, okay, every single person who's diagnosed with cancer under the age of 40 should be seen and evaluated at a specialty center. That's kind of at the beginning of the general AYA guidelines in the NCCN. They said, okay, you know, it's a fairly common disease, that's just not practical. And so let's give some specific indications to clinicians for when they should definitely prioritize referral. So we suggested de novo metastatic disease in AYAs, recurrent cancer after standard initial treatment, interest in fertility preservation if people need to get that done prior to the start of therapy, potential interest in clinical trial enrollment with the idea that specialty centers will have more trials open, and also locally advanced cancer. And this is an algorithm for the paper that just pulls out some specific management differences for AYAs in comparison to older women with cancer. And so first, laboratory tests and imaging for people with earlier, so systemic scans looking for widespread metastatic disease begin at an earlier stage than in older women. The clinicians who care for perimenopausal women a lot note that it's important to clarify the menopausal status, and if somebody hasn't menstruated recently at the time of their diagnosis, one can check their hormone levels to assess the menopausal status. Genetic testing that occurs as soon as possible after diagnosis is paramount, and of course you want to test the germline, not just the tumor. And with particular germline mutations, there is a strong likelihood of second tumors in the breast or elsewhere, and increasingly strong recommendations to consider bilateral mastectomy. So having AYA seen at a center that can routinely and quickly get that genetic testing done before surgical decisions are made is really important for AYAs. And then there's fertility preservation and prompt referral to a reproductive endocrinologist for oocyte or embryo cryopreservation if the woman is interested, and a GnRH agonist can be added to any chemotherapy regimen by the clinician. For some reason, this isn't advancing for me now. I moved my bar. Can you help with this? Tech support people?
Try to click on the slide and hopefully that should get it advancing again.
Let's see. Yep, thank you. All right, so lifestyle supports. Young compared to older women may have very different goals for what they want their physical activity to be after chemotherapy. And so it's important to ask them and to get them the physical and occupational therapy that will get them active and doing the things they want to do after cancer. Psychology and nutrition consultation can be very important too. Contraception is always a conversation, and a gynecologist can help with this. Copper non-hormonal IUDs are a good choice for people with hormone positive breast cancers. Barrier methods or sterilization, either of the patient or her male partner, are options for contraception. And of course, considering a clinical trial for any AYA with breast cancer is very important. So the last topic I wanted to go through with you was the checklist that Julie Graylow and her colleague Rachel Young made in their editorial that went along with this article. And it goes with Atul Gawande's checklist manifesto recommendation and his observation that in the surgical world, having and using checklists routinely has led to markedly improved outcomes in whatever a checklist is being made about. And so when you have a complicated process that's very specialized, particularly like breast cancer in young women, which is a rare population even within oncology, then a checklist can really help. And one can use the clinician's knowledge and experience and then study the process of how making and using a checklist improves your clinical practice. And so I will just go through the elements of what they put in their checklist, again, based on the content of the article. So first of all, having a lower threshold for systemic staging, looking for metastatic disease, the importance of genetic counseling and testing. We'll go back to this. Referral to fertility preservation, the careful discussion of surgical options, and making sure they get to talk to a plastic surgeon and get the best reconstructive option for them. Talking about the risks and benefits of prophylactic contralateral mastectomy, because the lifetime risk of a second cancer is a third, and for some patients even more. The chance of a second tumor is quite high for AYAs if they have a unilateral mastectomy at diagnosis. They, in the checklist, consider recommendations for systemic therapy, including offering clinical trials whenever available, thinking about age and menopausal impact on genomic assay prediction of chemotherapy benefit, considering whether ovarian function should be suppressed as part of therapy, considering whether a bisphosphonate should be used, looking carefully at psychosocial needs and addressing these as part of the routine clinical care, and recognizing that peer support is much more of an issue for this population compared to older women, that kind of a close reliance in the peer group is a normative part of adolescent and young adult development in that stage of the lifespan. And so peer support programs within the organization or referrals to local and national organizations that do peer support are really very, very important for this population. And then looking at the impact of cancer on career and occupation, and also finances and supporting patients in those domains as well. Screening for second primary cancers, both of the breast and in other areas, and giving appropriate referrals, particularly for germline mutation carriers who are at risk for cancers in other areas of the body. And then in survivorship, monitoring for side effects, particularly of estrogen depletion and early menopause, and asking patients about those because they might not mention them proactively to the clinician. We've talked about providing appropriate referrals, monitoring bone health and cardiac health during survivorship, and also really educating people about lifestyle, healthy habits like nutrition, exercise, maintaining of a healthy weight, and tobacco, alcohol, appropriate sleep hygiene, etc. And then for patients who progress and are not cured, they may have a lot of issues regarding facing mortality at a young age, as would be expected, and may need, additional resources and providers in palliative care who are specialized and able to take care of patients who are younger versus elderly. So thank you very much, and I'm interested to hear if anyone has questions or comments. Let's see, I see one thing in the chat. Nope. All right, we'll move on. Next, Dr. Nappi is going to talk about S1823. Yeah.
Thank you, Becky. I'm going to give you an update about our clinical trial S1823, which is a prospective cohort study to validate microRNA 371 in plasma of patients with early stage newly diagnosed testicular germ cell tumors. So I'm one of the chair of the study with Dr. Nichols. I have done this presentation many times already, but I will just summarize the most important basic science points about microRNA 371, which is a small microRNA, and it's expressed in more than 90. Oops, can you go back? I don't have control over the slides. Yeah. In more than 90% of patients with testicular cancer, both seminoma and non-seminoma, and it's specific for active germ cell tumors, so it's not expressed by teratoma. And the only other condition where we can find it is pregnancy, which doesn't really apply to our patients population with testicular cancer. It is very abundant in the peripheral blood, and it's easily detectable in serum and plasma. It is correlated with clinical stage, so we expect lower concentration patients with stage 1 and higher concentration patients with advanced disease. And it's rapidly cleared after the tumor is removed or after effective chemotherapy. And this is the heat maps in the tissue of patients with pediatric and adult germ cell tumors. Comparing the expression, these clusters of microRNAs are very similar to each other, so they belong to the same family, to normal, healthy testicular tissue or teratoma. And as you can see here, there is a net separation of the heat map, and the expression is very high in the seminoma and non-seminoma tissues, but it's very low, almost non-existent in the normal tissue. So this highlights the high specificity of this biomarker in germ cell tumors. Next. And based on these data that were available in tissue, we decided to conduct a pilot analysis looking at our biobank in British Columbia. And what we saw was that essentially this microRNA, can you go back, was expressed by most of the patients where we were able to find viable germ cell tumors, and across the spectrum of germ cell tumors. So in early stage disease, as well as in advanced stage disease, in the pre-chemotherapy setting and the post-chemotherapy settings in patients who harbor active germ cell malignancy. So overall, when we did the analysis of all the samples analyzed, and we analyzed 132 samples in this study, the sensitivity was 96% and the specificity was 100%, because there were no false positive results in that analysis. And therefore, the positive predictive value was very high, was 100%, and also negative predictive value was 98%. Next slide. So where are we at in the pyramid of clinical validation, this biomarker. I would say we are here like close to clinical utility, but we still have to demonstrate clinical utility of this biomarker. And therefore, we decided to design S1823 that has a very simple question. Can we use microRNA 371 to predict relapse in patients with clinical stage 1 disease after the orchiectomy? So in S1823, the patients are, all the patients with testicular cancer, germ cell tumors in general are eligible. And based on their baseline tumor markers and CT scan and histology, they are allocated in 3 groups: low, moderate, or high risk. Next. And after the orchiectomy, we collect blood samples with a different schedule. It really depends on what group category the patients are allocated to after the enrollment into the study. So for the low risk patients, we only require additional blood samples to be collected every 6 months. Up to 3 years. And for the moderate risk, we require blood samples every 3 months. And next slide, for the high risk, prior to active treatment, that can be chemotherapy or surgery, post-treatment, and prior eventually post-chemotherapy surgery. Next slide. So the design is extremely simple. We just need additional blood collected in Streck tubes at baseline post-orchiectomy that is required for all the participants to the study. And then at the time of regular clinical observations, we only dictate at 3-6 months, but the patient can be seen obviously earlier or according to the investigator's schedule. And then the samples are banked nationwide and are shipped to Vancouver to my lab for the microRNA analysis. But the microRNA is not done in real time. Previous slide, please. So the primary endpoint of S1823 is to establish the positive predictive value of microRNA 371 in predicting active germ cell malignancy in the real world germ cell tumors, and to establish by how much time, if at all, the microRNA 371 expression detection precedes the identification of the recurrence in patients with early stage germ cell tumor. There are a lot of secondary endpoints that will derive from this study. And one of the most important tools for secondary analysis is essentially that we are going to establish a clinically annotated biobank for patients with germ cell tumor that could be useful for future translational study, but also population study and quality of life study and survivorship studies. So every patient with newly diagnosed germ cell tumor is eligible for S1823. And the patients, also patients with more advanced disease, not just stage 1 or stage 2 disease, as they will be allocated to the high risk group. We target 50 relapses in seminoma, stage 1 seminoma, and 100 relapses in the clinical stage 1 non-seminoma. And the total number of patients is 957, with 806 patients with low moderate risk and 150 patients with more advanced disease. So the study was opened in June 2020, and the first patient was consented in July 2020. And the first Canadian patient was enrolled in December 2020. And we have almost 300 patients enrolled in this study. Next slide, please. We are working on a second version of the protocol to review the baseline patient's characteristics that are required for the group risk allocation, and to modify some of the eligibility criteria to facilitate patients' enrollment, and also to collect the blood samples during the follow-up. In terms of funds, we have funds to cover 3 samples per patient And we are still waiting for the funds decision from another one that was scored very highly. Next slide. I think that's it. Yeah, thank you. Do you have any question?
Lucia, were there any surprises for you in this study in the last few months, either in terms of accrual or in terms of any new findings? Or is it pretty much exactly like you were hoping for in terms of those things?
So COVID slowed down the activation of the study. So we expected to activate the study much earlier, but because of the pandemic, that was delayed. After the study was open, there were some sites that had some issues because of COVID again. So I think there have been some issues because of the pandemic, but overall, I think even if we are not operating 100%, we are still like within what we expect in terms of accrual for our patients, which is good. The other things that we have noticed during the first year of this study being active is that there are some there's some confusion with the group risk allocation. So we are almost in real time reviewing the group risk attribution, try to correct that early on so that the follow-up schedule is not affected. And we are trying with the second revision of the protocol to make less work for the site and accommodate with more flexible schedules, less number of samples to be collected, especially in the moderate risk group, so that like the sites and investigators can respect the minimum requirement for the follow-up schedule for the blood samples. We haven't analyzed any sample yet because we were waiting for some more events in terms of relapse, but we're planning to start analyzing the baseline samples. So we'll know more probably next year for the spring meeting.
Great, exciting. Other comments or questions? All right, I'm going to call on Jonathan Summers, who I believe is in the audience here, and I know had this type of testicular cancer. Jonathan, what do you think of this study from the patient's perspective? And if you were going through again, would you enroll? Sorry to put you on the spot. He says he's muted, so he can't talk. All right, next time, Jonathan.
Oh, I can talk now. Hi,
Okay.
Jonathan. In 2012, I was diagnosed with a testicular cancer. It was a mixed germ cell tumor, 90% teratoma and 10% seminoma. I should preface this by saying I am not a doctor. I'm a filmmaker. So if I misunderstand this study, please let me know. But as I understand the study, I would have loved to enroll in this trial because at the time, they weren't sure if after my orchiectomy, if I should potentially do surveillance or have the RPLND surgery. I will say that it was brought up to me that if you are considering surveillance, you have to be someone okay not knowing. And I was very anxious about I just wanted a definitive diagnosis. And that's what sounds really appealing about this study. So I chose to have the RPLND surgery. And my lymph nodes came back negative, and I was very happy to have that. However, I developed medical issues later. About 6 months later, I developed a small bowel obstruction, and I was hospitalized for that and had surgery. I also had many bouts of vomiting and lots of stomach issue, which led to a Mallory-Weiss tear. So that being said, as a patient, I'd be very interested in this study, because as a patient, we go to you doctors as the experts, and we really put our faith and trust in you. And when given an option, it kind of puts us in a bind, because we're not necessarily well-versed in this. We just want to live. So we'll likely do whatever you recommend, unless we're personally at odds with it. So I think this study would have prevented me potentially from having this large surgery. And I am excited to see where it goes in the future. And thank you for letting me chime in.
That's great.
you.
Yeah, it's so interesting to hear a real world perspective of how a serum biomarker would, potentially prevent a lot of morbidity. So thank you, Jonathan. Thank you, Dr. Nappy. Go ahead.
Thank you.
You're going to say something.
Yeah. No, I was going just to thank Jonathan for his comment, because his situation is exactly the kind of situation that we would like to avoid. So making sure with the biological marker that there is not tumor, or on the other hand, there is tumor, and therefore use some active treatment in the form of surgery or chemotherapy. So yeah, thanks for your comment, because this is exactly the clinical setting where this biomarker could be extremely helpful.
If you would like to talk offline, I currently mentor testicular cancer patients going through treatment, because you go from diagnosis to surgery pretty quickly. So perhaps we have an opportunity for synergy offline. I know Becky has my email, and we could get in touch. I would like to discuss it.
Yeah, absolutely. Thank you. Thanks.
Excellent. All right. Thank you both. And next up, we have Dr. Eitan Orgel talking about his asparaginase toxicity study. Dr. Orgel.
That's better. I can say hello, everyone. Becky, are you advancing the slides, or am I? There we go. So just want to say thank you to everyone for giving me the opportunity to come and talk to you today. I'm a pediatric oncologist, so well out of my depth in this group, located in Los Angeles. And this is a trial called ACCL 1931. It's a randomized trial of levocarnitine prophylaxis to prevent asparaginase-induced liver toxicity in AYA patients with ALL. So well known to those taking care of these patients, pediatric-inspired regimen, or so-called pediatric-inspired regimen, contain asparaginase, which is a fantastic drug to induce remission, but unfortunately, and particularly in the AYA population, tends to have a lot of toxicity. This is data from the C1043 and CTN trial showing induction toxicity in that first month. And I highlighted the topic for our trial, which is the liver toxicity. And so as you can see, it's a very common toxicity. And in addition, as indicated by the bright red arrow, as you become more and more obese during induction therapy, as one might expect from a liver toxic agent, you tend to have more liver toxicity. On the bottom is the pediatric data. We actually have not yet reported our COG ALL trial data in a large scale format, though we're working on that now. And so these are two smaller studies. One is a single institution study, and it uses the conjugated bilirubin as a threshold. These are the most common dose limiting criteria in pediatric regimens and now in the contemporary adult regimens as well. And as you can see in the top row, in the younger age patients, it's only about 4%. But even in that study, of the 15 patients who got toxicity, 14 of them were over 10 and over half were in the AYA age range. And the bottom study is a more recent trial where we looked at a retrospective real world experience from 10 centers. And using the contemporary threshold of a conjugated bilirubin of 3, we found that 16% of patients developed this dose limiting toxicity. And just like we saw in the C1043 consortia trial, we also found that obesity was significantly risk factor for liver toxicity. And as you can see, not a small one. This data was also replicated in single institution AYA cohorts in older patients as well. Next slide. And when we think about obesity, I think it is important just to note that how common is the problem in the US. As many on the call know, the obesity epidemic is real and it is not going away. On the top is data from 2000 to 2016, and it shows the relatively slowly increasing and currently plateauing rates of obesity in the adults and youth in the US. And of course, the AYA population falls right in the middle of that. In the bottom right, the CDC has a surveillance system where it reports annual rates of obesity state by state and also by various other metrics if anyone ever wants to play around with it, including socioeconomic status and age-wise and others. And as you can see here, there's no state in our union that has less than 20% obesity in adults. And in fact, the healthiest states have 1 in 4 to 1 in 5 adults are obese. And meaning that when we're thinking of patients walking in the door to our clinical trials or to our offices, you should expect that you're going to encounter this probably on a daily basis. When we think of its impact on trials and on outcomes, this is, again, data from C10403, which is the AYA adult trial using the COG regimen. And as you can see here, overall survival decreases with increasing obesity, and significantly so. And we think about toxic mortality in the trial being less than 5%, so not directly causing mortality, and in fact, only about 2 to 3% in induction and maybe 1 or so afterwards. You know, the question that this engendered was, what is actually happening? How is obesity causing this? And one of the hypotheses was that obesity causes direct mortality through hepatic failure, but can also cause dose-limiting toxicity where you're not able to give the drugs necessary, and therefore, if you can't deliver the regimen, you're going to have poor outcomes, as one might expect. We actually looked at this in that retrospective study, and so we looked at those patients who had dose-limiting liver toxicity, and we found a striking effect on survival for those who did not have it, having markedly improved, and those who did have it, in the red line on the bottom, having significantly worse survival. As you can see by the rapid drop-off in the beginning, there is an early mortality effect, but also an early relapse and failure effect, as one would expect. This was from about 140 patients over 10 centers. About half the patients were between 15 and 35 years of age. And again, using the dose-limiting criteria of 3 milligrams per deciliter, which is the threshold for dose limitations on both COG trials, the current Alliance multi-consortia trial, and is sort of the contemporary threshold going forward. And so with its impact on therapy delivery, on morbidity, and potentially on relapse and mortality, there's been a look for how to approach this and how to reduce it. People have tried dose capping, which is one of the current recommendations in the DOL trial, dose limitations, PK, dose adjustment, all these different pieces. And in that milieu, levocarnitine is a drug that's come about and is being used off-label in many centers now to try and prevent or treat liver toxicity. And just to briefly reduce the rationale for this drug, asparaginase causes mitochondrial oxidant stress, dysregulation of fatty acid metabolism and transport. Levocarnitine is a key cofactor for it. It restores transport, meets the energy needs, and kind of reverses that balance. And there's a lot of clinical data from non-cancer populations for its beneficial impact on liver stressors. And a recent meta-analysis last year showed the results from 18 randomized trials, 1,000 plus patients, and showed a very, very clear effect of levocarnitine inclusion, reducing serum markers of liver injury compared to control groups across all these randomized trials. And so there's a lot of data from non-oncology populations that was generating enthusiasm that it might be able to prevent liver toxicity in ALL as well. From the preclinical data side, there's very, very limited mouse models and animal models that everyone turns to point to whichever side that they want to of this equation, that it works or it doesn't work. And A and B was the initial report from 2013. Just to summarize briefly, it was a obese rat model, and it showed that infusing levocarnitine with asparaginase reduced serum markers of liver toxicity, and in B, actually reduced fatty involvement and improved liver histopathology. In C was a more recent study, which was looking at a non-obese model and actually looking at a rescue model. So this model, instead of giving a concurrent or before the asparaginase, gave it after the asparaginase when the liver injury had already begun to happen, and they showed no benefit for rescue in this model. And one of the reasons I show this slide is just to emphasize that when we're thinking about how to interpret the data, that prevention is not the same as rescue. Using the drug to prevent the onset of toxicity is distinct from when we try and use a drug to rescue it from once it's already occurred. A key point that we have learned over the years, unfortunately, is that when we're incorporating into chemotherapy, we want to make sure it doesn't interact with the said chemotherapy. And so this is in vitro models from 2 different laboratories showing that with our induction chemotherapy, there's no interaction. And in fact, that there was no in vitro or other evidence that this was interacting with chemotherapy. So we felt comfortable moving it forward. And also, again, is currently being used off-label. The other aspect of safety, of course, is how well the drug is tolerated. And this is where we actually have the benefit of knowing that the drug has been tried for many other indications, including in SWOG trials, for fatigue, for neuropathy, for cardiomyopathy, I believe, and for others. And so there was a dose escalation trial showing there's no dose-limiting toxicity or major AE. Across these trials, it's been trialed in over 1,000 patients. And there's really just a very minor AE profile, some occasional GI upset, nausea, maybe some diarrhea, nothing that precluded taking the drug. Neuropathy is actually interesting. There are multiple trials showing that it may benefit. There was one large trial using taxanes and an alternative formulation that with prolonged usage of this agent, it could actually worsen neuropathy. And so there's equipoise that whether this is actually going to be a benefit or an off-target effect for it. And again, just to know, this is a different chemotherapy and it's a short-term usage. So we may not see an effect at all, but it is something that we felt important to note and to carry forward when we were designing the trial. From the real-world experience in ALL, wide range of doses. The most common dose is 3 grams a day. In a study of this 10-center study, over 4,000 patient days, most were on it for about a month, which is the length of our induction therapy, that first phase. And there was 0 AE reported in any patient over 10 years old. And so really, when we're thinking about moving this forward from a real-world off-label use to a phase 3 trial, it was important to know that it has a very, very well-characterized and favorable drug profile. From the efficacy perspective, one of the largest case series was that one I keep referring to. And in this evidence, about 50 patients received it, about half for prevention, half for rescue. And when used for prevention, after accounting for age and after accounting for obesity, there was a really strong efficacy signal found with, as you can see here, a significant reduction in the dose-limiting conjugated bilirubinemia. There was no effect of 1 versus 2 doses of asparaginase, which is probably not relevant anymore, considering that the COG is likely dropping that second dose from their regimens for the TAL anyway, but that's not firmly established yet. But there was, it looks like asparaginase in general, the dosing with the formulation was not impacting it, and ethnicity, interesting enough, was not significant in this small study. On the bottom, for those who are more visual, 1 second, Becky, just to go from odds ratios to probability, it just shows that if you're obese or AYA, you've got a 1 in 3 chance for developing toxicity. Levocarnitine reduces it significantly. And AST/ALT is far more clinically impactful in the adult consortium trials, but just to note, there was no formal significance. If you want to play the numbers game, the orange bars are lower, and I will leave it at that for people to interpret. And so a lot of recommendations that come forth. This is one from Danny Rim across town from me, and I just want to emphasize their conclusion, which is that larger studies are needed to confirm and better define this effect. And really the bottom line is we couldn't agree more, and which is why we're bringing this forth, this concept for NCTN-wide trial. And so it is a NCTN-wide, AYA-focused supportive care trial in ALL. All the highlighted words are important. And I would note that this is the first time a supportive care trial like this is being brought forth across the NCTN. I'm a huge fan of the far side. I think this cartoon probably speaks it all. And so hopefully the concept will move forward and be taken up once the trial is officially activated. It is a straightforward schema. It's a phase 3 randomized trial, 1-to-1. Arm A gets prophylaxis, about 3 grams a day, in the AYA population, certainly. We had to do it per kilo for the younger patients who may not actually meet that. And then the arm B is observation only, just no prophylaxis. And then because some patients may develop toxicity, we felt it's important to have the option of starting a levocarnitine if you're on no prophylaxis, or continuing it if you're on the prophylaxis. And again, noting that prevention is not rescue, and the primary endpoint, as you'll see, is in fact prevention of this. And we'll describe what happens for those who do develop the toxicity. The orange box I'm going to bring forward, because I'm going to say it at every presentation and every consortium I present is ever going forward, is it takes time for levocarnitine to have its effect on the liver. And so the earlier you enroll, the earlier you randomize, and the earlier you start the drug, the better it is, and the likely more benefit you get. So up to the day of asparaginase, but before, earlier is better. This is one of the reasons I was excited to come talk today, is to share some of the experience of developing a concept that goes between the COG and the other NCTN consortium. And so it really comes to a bit when we start talking about the eligibility and the details of the design. And so I'm going to try and pick those out as we go through this. It is an AYA trial, 15 to 40 years old. BAL or TL are the eligible population. And this was the first point that was really important when we started planning the trial, is that pH positive and pH like are both eligible. These are highly prevalent in the adult populations and far less so in the COG world. And so to make this as broadly applicable as possible, we felt it was really important that we include the more likely and more highly prevalent diagnoses. We are allowing basically any regimen, including asparaginase, in the first week. So any dose, capped, uncapped, PEG, CalPEG, whatever you're using, you do not need to be co-enrolled on the Alliance trial. And this, again, was really important for flexibility for centers. You know, we were talking whether we would do it as a COG regimen or COG-inspired regimen, but when enrolling across the NCTN, we know that there's a lot of different regimens that are used. And so really we're allowing any regimen that will allow us to answer our primary endpoint. And the bottom one is saying a lot of people have liver involvement at diagnosis from the leukemia. As long as your normal liver values at time of enrollment, you're okay. So whether you cytoreduce or hydrate or whatever it is, then you're eligible for study. Next slide. The trial endpoints was probably the biggest concept stage discussions, and I'll just highlight it briefly here. So the official primary endpoint for this concept is conjugated hyperbiliary greater than 3. This is in fact the dose limiting threshold on both the COG and the Alliance trial, and the contemporary one being put forth in recommendations. And we initially started this with a combined endpoint of ALT and bilirubin, because we know that ALT is important for the adult consortium and adult providers who are treating this disease. Over lots and lots and lots of discussions, because we have a shared endpoint for bilirubin and the ALT was less impactful, the sort of consensus was that we'll focus on bilirubin as the clearly dose limiting toxicity, and very much focus on ALT as an important exploratory endpoint, capturing the raw data we need to answer that because it's important in treating AYA patients. I'm not going to go through all the exploratory endpoints. We're going to look at risk factors like obesity and age. We'll describe the rescue arm. We are going to be looking at this neuropathy using a PRO, which was started in the AYA age range and brought forth into COG in the Hodgkin lymphoma trials. And because neuropathy is more common in AYA, we may be able to detect a signal for benefit, or hopefully not, for off-target toxicity, even in such a short-term trial. We'll be looking at survival. One of the key pieces, as I showed you before, is that toxicity may be impacting survival. And so the hope is that if we can allow patients to go ahead and get the therapy they should be getting, that we can improve the survival to what it would otherwise be without that toxicity. And we'll be looking at pharmacogenomics, et cetera. It's okay. From the details, we're targeting a 50% reduction. We need 400 patients, accounting for toxicity and mortality and dropout. We'll enroll up to 420. We're expecting the trial to run for about 4 years. As maximum, hopefully, we're somewhere between 2 and 4 is what we're hoping for based on accrual rates. We're going to randomize by strata. 2 strata, obesity, as I showed, is an important predictor of liver toxicity, and also NCTN group, COG basically versus the other, both numbers, but really to capture the different supportive care approaches that are present between the pediatric and medical oncology providers, and also to roughly cover the difference in age between the two, between COG and the adult consortium. There's a futility analysis. And as of this week, we have presented to NCI. We are under review and waiting their feedback, and we're hopeful to get that and have a favorable response to carry forward in the next week or so. And so we will be letting everyone know the update pretty soon. And so coming back to, when I was first asked to come talk, I wanted to share just a little bit of my experience in building the concept and some of the things that I thought were both helpful and some of the, I don't want to say struggles, but some of the hurdles or lack of knowledge I had to overcome as we went. And so I think the first step, the foundation, was what is a common area of concern? So this was a liver toxicity that was impacting us very much so in the pediatric side. And it didn't take a broad leap to realize that if my AYA patients were at risk, that this probably was affecting the adult ALL patients as well. And so this common area of concern to build around is one of the first foundational steps for actually building this kind of concept. The next one was actually identifying the champions and getting early input. And so reaching out to the NCTN, to Wendy, Selena, and Anjali, and really getting input for understanding what the nuances would be between opening a trial across all 4 consortia was extremely important, both to validate that this was in fact a common area of concern, that yes, this is something that would be exciting to ALL providers who are treating AYA patients outside COG, but also to understand what this might look like. And there were really important questions like, what's the primary endpoint? What's impacting care in the adult population that maybe we don't see on the COG side? The eligible age range, the 15 to 39 was the sort of the classic AYA. COG wanted to go lower. We thought maybe we should even go higher, but we kind of settled on this classic one, but it was also an area of discussion early. The AL subtypes I talked about already. The regimens, tying it to a regimen with a really limited enrollment and versus multiple regimens. And then the research setting I just want to focus on, because the COG and pediatric institutions have a really different research infrastructure. And so the reason we did a 1-month quick in, quick out trial was really to minimize the burden, to allow sites to participate in the trial across the NCTN, across community and core sites, across everywhere, and not have to worry that there's going to be 6 months or 9 months of repeated research data points to continuously furnish, and really hope to foster enrollment across sites by limiting the burden of the reporting to what's necessary for the primary endpoint. And just a few things to highlight. We have very different procedures. COG is a centralized process. We have a stamp of approval from our scientific council. And once it's approved, it's approved. It took a lot of explaining that there was no such process outside of this, and that it's really an enthusiasm approach that, yes, everyone's excited. We just need to keep moving it forward. And so that was really something that we had to navigate within the COG, that there wasn't like a formal approval I could submit to them and say, we are okay now. The treatment landscape I touched upon, very different. What is standard of care? What are the regimens? What do we have to account for? And the biggest, I think, surprise, or perhaps not, but was the duration of the process in the COG. I first reached out to our champions in 2018, and it took about 1.5 to 2 years to go through the COG process of getting sufficient data to convince them and get the approvals and finally move forward. And so maintaining the enthusiasm, maintaining the engagement along that process was challenging, but I think really important. And that, of course, took the revisions. And every time there was a revision, we had to go back to the drawing board and say, how does this impact all the different groups and all the different stakeholders? And so with all that, I think I would just highlight that champions are crucial. If it's coming from the from SWOG or other adult NCTN consortia, finding someone on the pediatric side, from the pediatric COG side, I think we're very, very much appreciative of the joint decision-making process. And from talking to the RAYA landscape and many in it, we recognize that really what sets these things up for failure is when there's not early input, and we kind of trying to develop a ready-made protocol to others, as opposed to saying early on, what are the nuances involved? We have different settings, different populations, different ones, and let's find the common ground to do it. And so early champions on all ends is probably the most crucial thing I can say that helped bring this forward. And of course, the village, as we call it, for who's involved and helpful. And I call this not the village, but actually the most terrifying slide of any presentation. And so I would like to thank everyone on the slide, my vice chair, of course, everyone in COG, my coordinators highlighted, Michael Roth, who many of you know from the AYA side, and of course our champions from the NCTN side. And if I forgot anyone, I am deeply apologetic and sorry, and I am thankful for all your contributions. And I'm sorry if you're not on this slide. Again, the most terrifying slide of all. And with that, I think I left enough time for some Q&A, and happy to join the discussion.
Thank you so much. What a fascinating presentation. I have a couple of questions. And first, I wanted to see if anyone else has some. Go ahead and speak up if you want, or post in the chat, whichever you're most comfortable with.
There is, Becky, there is a question in the chat.
Oh, perfect. Let's see. How do you distinguish weight gain from steroids for ALL patients and that caused by liver toxicity? So how do you distinguish weight gain from steroids?
So from our perspective, we're taking everyone as they walk in the door. And so, right, so the obesity we're talking about is obesity at presentation, sort of setting the stage for failure from adding the chemotoxic agent on top of it. As an obesity researcher, I would say that you can't. And so weight gain in the first month is really tricky, as I'm sure many have experienced for many cancers. You know, we have the sarcopenic obesity is this thing that we experience as well, where people lose muscle mass, gain body fat, and weight does not reflect that. And so my general take on all things ALL, steroids or not, or cancer or not, is your starting weight is probably a generally true reflection of your body composition. Anything after that, it's really tricky to do. And so that's why we're using starting weight for that reason and others.
Great. And how are you measuring the supportive care differences? What data fields are you collecting?
So this is something that is tied to one of our exploratory aims. We're going to track chemotherapy delivery because we think that's an important threshold, and the comfort with which pediatric oncologists blissfully continue forward with their therapy versus sometimes more hesitant approaches in the older AYA populations. Hopefully that will capture some of that. We're also going to capture those who stay inpatient for their entire month versus the pediatric side who tend to go home. And unfortunately, beyond that, I think we're not going to be able to capture a lot of the more subtle approaches to this. The hepatic rescue, for those who do have toxicity, we will capture concomitant medication. And so we can see some of the vitamin B complexes or ursodiol, other things that have come about in the AY age range. But the more subtle ones, I think, will be beyond us, and one of the reasons we're stratifying by consortia.
Great. Interesting, a couple of years ago, we were looking at doing a retrospective study on the impact of high BMI on outcome in AYAs treated through SWOG, and it turned out that it was really hard to capture BMI through the data fields that were collected. And so I wondered if there was anything different that you had to do in this study, or if it's just standard. It's obviously not a hard set of data points to collect if you prospectively want to do so.
So this is an ongoing fight of mine within the COG, where this data fields come in and come out of the studies, depending on whether we can tie it to it. And currently is back in our AOL1, so we can capture it again. We had a generation where it was not. And so I think the answer is that because it's a target approach and part of enrollment criteria, we're going to get it, because you can't really enroll without your height and weight on this study, because we need to know which strata you are. So we will have it for this study. How to capture on a broader consortium level is a challenge I wish I had the answer to. But for this study, we should be able to get that fields.
Cool. And I appreciated your discussion on the early champions and involving people from multiple groups, in the design process. And I wondered if you could just comment on the earliest phases of it. This was your idea, presumably, you and Mike Burke, to do this project, and then you reached out, but these were co-investigators that you knew who they were and you talked to them routinely. Is that correct? Or how did you set up the collaboration?
So Wendy and I have crossed paths. Wendy Stock and I have crossed paths here and there in the asparaginase world. And so once we had the concept, I knew that we needed that. And I actually reached out to Wendy, who helped connect me to Anjali and Selena early on. And so, absent that, because I do get this question from some COG colleagues who are looking to do similar projects, we do have the AYA committee in the COG, as you know. And so I think there is opportunities to make these cross consortium collaborations. And if you don't know someone personally or encounter them along the way, then there are resources, at least in our group, to help do that. And hopefully in the DOE consortium, well, again, with yourself and others, Beck, you can reach out and say, hey, we have someone interested in just to go back to the recent study in a germ cell trial, how can we do this across the different consortia? And so there are ways to cross that bridge, even if you don't know someone. Hopefully you have that committee who can help.
Yeah, it's great when it happens, and it is, I think because of the varying committee structures for the disease groups of the different NCTN groups, it can be surprisingly difficult. And so it's good that you got that done, and it will be great to see the day when we can easily contact others from every group who are interested in the same things we are.
I hope so. And I hope that I am in the COG. I can help you find anybody. Just feel free to reach out. Again, sometimes it's just finding that one person for the entry point. Michael Roth, others, David Fryer and others, many people who I think across the way. So just, but I can't emphasize how important having that early champions were to developing this and having the input, even if it was like every 6 to 7 months as we got feedback along the way, just to know you had the contact points to reach out, to bounce ideas off of and adjust as you needed to, was so helpful that I couldn't imagine doing this concept without the three of their input along the way.
Yeah, fantastic. One final question is, what accrual do you expect from the COG versus the adult groups? Do you have a sense of that at this point? So
this is sparking lots of discussion because traditionally COG has done the bulk of accruals on this type of trial, where it's been more of a 2/3, 1/3. I think because of how we structured it and because of how it is, I'm actually anticipating hopefully more of a 50-50 accrual. And that's based, of course, on the prevalence of the disease, but also the accrual rates across the 4 consortium. And so I think the base would be 2/3, 1/3 expectation, but hopefully more than that, more of an even spread, just because of the prevalence, but also the prevalence of the toxicity that makes it have a higher level of concern engagement in adult sites.
Yeah.
But I'm an optimist.
Well, that'll be great. I hope you can get 50-50, because that'll be an interesting mix of patients to compare. Thank you so much. I appreciate your coming.
Oh, thank you for having me. Thank you, everyone.
And next up, we have Dr. Micah Roth from the COG and MD Anderson to talk about patient-reported outcomes. Mike, are you on?
I'm here. I hope you can at least hear me.
Yes.
Okay, perfect. I'm going to share the slides. And just let me know if you can see them okay.
Yeah.
Perfect. Well, I want to thank you, Becky, for not just inviting me to talk today, but for your collaboration and partnership through the years. I think we have done a lot of work together between SWOG and COG, and a lot of it is, just like Eitan was talking about, personal relationships and really just wanting to do good work and do well by our patients. So this is one of those, true AYA efforts. This is a true collaborative effort where we're really focused on trying to understand the AYA experience during and after treatment in terms of how it relates to health-related quality of life and toxicity. So this is a CCDI-funded effort with Susan Parsons and Brad Pollack, and you'll see many other folks are involved. So the rationale for focusing on patient-reported outcomes in our AYA trials is that traditionally we have not focused on this area. For many, many years, there's just been a lack of symptom research and toxicity research within the AYA population, and specifically asking patients to report their quality of life and toxicity outcomes. In addition, when it has been included within our AYA clinical trials, the domains that have been assessed and the types of inventories that have been utilized to assess these health-related quality of life domains are really all over the map. So there's really a true need to standardize and harmonize what we're assessing and how we are actually assessing these items. So our primary aim for this larger initiative is to come to consensus on a core battery of previously validated PRO instruments, and PRO stands for patient-reported outcome instruments, and really help include them into upcoming AYA clinical trials. And this is a manuscript our group published the past year, which really provides some of that background data. So we looked at a 14-year period, all AYA-relevant studies that were registered within clinicaltrials.gov. And we wanted to identify how many of them included a PRO endpoint, and we found about 1 in 5 of all AYA trials. When you look over time, it's really not changing. So it's not that, in 2007, those trials didn't include a PRO endpoint, and 2019-20, we're doing much better. We're really sort of somewhat flat on the curve. And when you looked at those studies that actually did include PRO endpoints, and you looked at the inventories that they utilized, the table on the right shows you that it really is all over the map. And the types of inventories and the actual inventories that were included, they were all different. And thus, it was really difficult to compare outcomes within disease groups, across disease groups. And within this manuscript, we also published data looking at breast cancer and colorectal cancer trials. And what we found is it was the complete opposite. 40 to 50% of those trials actually included PRO endpoints, and they all used the same inventories. So we're really lagging behind in our AYA trials. So we came together with this initiative, and what we did is we identified experts from across the NCTN. And this really was probably the hardest part of this initiative, was really being thoughtful about who should be included, what expertise did we need, and then how do we get buy-in from everyone. And I think this slide is the one we're most proud of in this initiative. Becky's been a longstanding member of this group, and we have representation from every single research base, and we really focused on including 3 main experts: those who have expertise in AYA oncology, those who have expertise in AYA health-related quality of life, and others who have expertise in incorporating patient-reported outcomes into NCTN trials. And you can see some of the domains that were prioritized in the table below. So the key questions that we brought to this task force were a number of them. The first ones are, we're going to ask AYAs what's most relevant to them, what domains to assess, and it's most important that we really get a sense of what's the current data in terms of what AYAs want us to know about. And importantly, we have experts on our task force who've done these studies, and what we found is that, through the developmental age spectrum, there's sort of different interests in terms of what's most relevant to our adolescents and young adults. A 15-year-old has very different needs than a 37-year-old, and it's important that with the core battery, we actually capture and can assess those differences. Other things that came up on the task force is, how do we minimize the burden but maximize the data that we actually obtain? How do we take a deeper dive into, fewer domains, or should we actually be asking about more domains but ask fewer questions? And when you're starting essentially from scratch in terms of our limited knowledge about health-related quality of life outcomes for our patients, these were really key questions that took up quite a lot of time and we were very thoughtful about. I think the most important approach that was needed is really being adaptable and flexible. If we want to recommend a core battery across different trials, it has to be adaptable to different disease groups, different therapeutic approaches, different approaches in terms of immunotherapy versus traditional chemotherapy. And we needed to make sure that folks knew that there's not a one-size-fits-all approach to this. We really needed to add in flexibility to the core battery so it would be utilized and be useful. So we worried in the beginning that we wouldn't be able to come to consensus on this core battery. And the main reason why is because there are so many different experiences and backgrounds of our experts. And whether you come from pediatric oncology or medical oncology, whether you focus on breast cancer or pediatric leukemias and the younger AYA leukemias, we weren't sure whether we would be able to agree on a standardized approach. But the guiding principles that really led the way and helped us move forward is, one, most importantly, we need to focus on that which is most important and relevant to our AYAs. We did need to select those inventories that were previously validated in the AYA population. We did not want to reinvent the wheel. Flexibility and adaptability were really, really key. And then we also wanted to use measures that were available within the public domain and also translated into multiple languages. This is really our chance to understand the experiences and outcomes of our patients on and post-treatment, and we did not want to limit and exclude patient populations that were relevant. And we also wanted to make sure that we didn't increase the patient or site burden too much. Ideally, you can ask 200 questions and get all the information that you want, but we also know that's not realistic and feasible, and it's not fair to our patients. So this is about a year's worth of work summed up in one slide, and it tells you our kind of big picture approach to the core battery. The top half, which is in blue, labeled the PROMISE AYA Health Status Profile, is really our focus on health-related quality of life measurement. And the bottom half in gray is focused on measuring toxicity and symptom burden. What our approach is really guided by is measuring more domains with fewer questions. So we wanted to leverage the PROMISE short form inventories, which they can be as short as 4 items. They are validated individually, and you can swap in or out those domains that are most relevant to your patient population. So you can see the box on the right side here gives you a potential PROMISE AYA Health Status Profile, which includes depression, anxiety, pain interference, but you can actually swap those out for other relevant domains that are within the PROMISE short form tools. We also gave a recommendation that if you have a primary endpoint that is a health-related quality of life domain, that you should probably go up to at least the 8-item inventory, which will help with some of your power analyses and other statistical support. We give administration times. This is flexible, but overall we recommend administering the battery at baseline and then into survivorship, with a few periods during the treatment period. And the reason for that is that our patients' symptoms and quality of life, things don't just go back to normal once you stop therapy, and we've learned that. And for the AYA population, we have an overall cure rate of about 85%, and that's really why quality of life and toxicity has been only recently kind of pushed to the forefront. It's not just about cure anymore. It's about what types of lives are our patients living during and after treatment. The bottom half, we recommend leveraging the Pro-CTCIE, and for the younger patients under 18, the PEDS version of the Pro-CTCIE, but also just like Eitan showed in his study, using a symptom-specific inventory when relevant. So ATON specifically worried about neuropathy, and there are very good tools that are patient-reported for neuropathy. So we would recommend using a hybrid version, making sure we're measuring those toxicities which you expect to find. Administration time is basically when you anticipate seeing those symptoms and administering the battery at baseline during those key periods, as well as into survivorship. Total completion time we anticipate will be anywhere from 10 to 20 minutes, and we'll talk about electronic data capture as another way to minimize patient and site burden. For those who are not familiar with the PROMIS short-form inventories, they are very straightforward and easy to complete. They're anchored in your symptoms over the past week, so the past 7 days. To what extent have you, how often have you experienced these symptoms? And they cover a wide range of health-related quality of life domains. And for those not familiar with the PRO-CTCAE, here are all of the different toxicities which the PRO-CTCAE covers. And many of the symptoms and toxicities include frequency, severity, and amount of that symptom, with or without interference. And then some just have either the toxicity is there or it's not there. On the right side of the screen here, you can see some examples of nausea, which has a frequency and severity, and then abdominal pain, which also adds an interference. So we have very good support for incorporating the PRO-CTCAE and the PEDS PRO-CTCAE in AYA trials. I think one of the most successful AYA cross-network trials to date has clearly been the SWOG 1826 Hodgkin's trial. This is a study of backbone of AVD and randomization of nivolumab versus brentuximab. It's a great study. What I can say is this is a truly collaborative study. COG has enrolled a third of the patients on a study led by an adult network group, so it shows that we definitely can, are willing, and would like to enroll our patients on those studies which we think are important questions. And the hope is that as more and more therapeutic trials are moving forward that are cross-network, that we get this wonderful cross-enrollment. Within the S1826 study, there are very purposeful health-related quality of life and toxicity endpoints. And with more than 570 patients actually enrolled on study so far, we've had wonderful completion rates over 80 to 90%, and we've not needed to increase the number of staff at the site level because we've incorporated electronic data capture. So a lot more I can go into here, but this is just a proof of concept that this is definitely feasible. The patients complete these inventories, and it really will provide new data on how our patients are doing during and post-treatment, which can actually define the standard of care, specifically with a study like this, where outcomes are actually expected to be quite good on both arms, and quality of life and toxicity may be what's needed to pick the winner. So we realize anytime we're recommending including another inventory into our sort of standard of care for our trials, there's many questions that come up. We developed a pretty straightforward frequently asked questions document, which we will circulate to Becky and others. And really, we're sort of going on our roadshow, as you see here, trying to circulate information about the core battery to as many people who are key stakeholders as possible. Within this initiative, when we think of patient-reported outcomes, we're not just thinking about health-related quality of life and toxicity, but we're also thinking about other areas that focus on disparities. We know that hospital-reported data on race, ethnicity, gender identity is often inaccurate, and the best way to get this information is to actually ask the patients themselves. Using registries like SEER and others, when you look at socioeconomic status and material hardship, they have their limitations because they're focused more at the county level or census tract data as opposed to the individual level. So under this initiative, we also developed a sociodemographic working group, and we have developed a standardized form for the AYA population, which seeks to collect this data, including gender identity, sexual orientation, and other areas that might sort of have disparities in care and outcomes, which traditionally we have not been able to study because we've not captured this data appropriately. So we are doing this across COG. We're actually in the process now of reaching out to colleagues within SWOG, Alliance, Energy, and others to see, if we can standardize this ideally across the NCTN. So definitely a lot more collaborative work to be done. I think there's so much that we don't know about disparities within the disparity of being an AYA, and I do think that's what's sort of coming up next. Along those lines, it matters how we actually ask our patients to complete this data. So within COG, we've been behind the times in terms of using paper and pencil and then having our sites track patients down, wait for them to complete their data, collect the data, manually re-enter the data into a database. This has, lots of opportunities for error, human error in data transfer. It's a big burden on the patients to complete the data sheets when we want them to complete it. It's a big burden on our staff to track patients down. We should be using texting, email, other mechanisms of data, electronic data capture, so patients can complete it at their convenience. And that's really what we're shifting to within COG, and we're going to pilot this within a number of our studies. This is our progress to date. So we're 1 year into this grant, and we already have 5 trials that are incorporating and adapting our recommendations for the AYA-PRO core battery. First trial to do so is a cross-network osteosarcoma study. It's actually a surgical question. This is an ideal study to start with because it's a pretty small trial in terms of the sample size. It's a surgical question focused on pain, and most of the endpoints are within 6 weeks. So we'll be able to ask and answer some of these questions quite quickly. I actually think that Eitan study, which he just presented, is another ideal study, which we are working with him and his colleagues to pilot this core battery as well. And in addition to studying, the feasibility of incorporating the core battery, we're looking at logistics of expanding the use of the core battery and electronic data capture to some of the larger studies, such as our ALL and Hodgkin's trials. So more to come on that. We're actually studying the process of this data collection. So it's not just looking at the endpoints, but it's feasibility and logistics of what do we need to do in terms of resources and centralizing some of the resources as the shift or the burden will shift from the sites with electronic data capture a little bit more centrally. So anytime I get to talk with colleagues across the NCTN, I like to take a step back and sort of look at where we are, how far we've come, and what my vision is for AYA cross-network clinical trials and next steps. If we think about what's been the major barriers to really identifying and optimizing AYA cancer care delivery and outcomes, a lot of it has been sort of just barriers and longstanding differences in approaches to care, treatment settings, and a lack of harmonization of treatment approaches across pediatric and medical oncology. And I think we've come a long way in the past decade. We are at a really great point now where there's never been more cross-network AYA trials open and active, and we have a ton of AYA concepts that are actually moving forward pretty quickly. So it's really a great time to be an AYA oncologist. I think traditionally there's been limited collaboration, and Becky mentioned some of the challenges that still exist of identifying those folks across the aisle, because we often just aren't in the same meetings. So I wish many of these meetings, I think the virtual setting has helped. Obviously there's some fatigue right now setting in for all of us, but having more of these meetings where we focus on the population, and it's not just a medical oncology meeting, but or a pediatric oncology meeting, but it's an AYA focused meeting. I think the Germ Cell Group has done a fabulous job internationally, really focusing on the disease as opposed to the age specifically, and I think we really need to learn from them and the Hodgkin's folks who've done this for many years now. AYA enrollment or lack thereof of AYA enrollment has been a huge challenge, and we're trying to tackle this. We're doing better, but I think we need to make sure that we really continue to focus on not just enrolling AYAs, but making sure that we're not excluding different AYA subgroups, and making sure that specifically in the community setting, we're enrolling these patients, because there is great concern that patients in the community setting do have poorer outcomes compared to the academic setting, and we're trying to figure out why that is. Where I think we need work, and I was so excited to follow Eitan, is that we have a limited understanding of supportive care approaches or optimal supportive care approaches within AYAs. We know that in pediatric oncology and medical oncology, supportive care has improved survival for so many patients, looking at transplant, looking at induction chemotherapy for patients with leukemia. but there's really been few studies looking at supportive care approaches within the AYA population, and there's so much work we need to do. There's so much work in CCDR research, we need to do, and I think now's the time, and I think it just needs a push, meaning therapeutic trials are moving forward. To me, that next step is really moving towards the supportive care studies. So like I said, the restructuring of the NCTN, I think, has been wildly helpful for AYA trials. And, for us, moving COG closer to the adult groups has been, I think, years ago was a struggle, and now it's getting a lot more fun and enjoyable because being able to have a seat at the table and collaborate, we all want the same things, and we're in a place now where having these types of discussions and talks is becoming more of the norm, and I'm hoping that all of the AYA trials moving forward, or for those AYA relevant diagnoses, we continue to make that progress in developing these studies together at the earliest stages. We tried in the very beginning 10 years ago when this was just starting out. COG would develop a trial and then the last second invite our medical oncology colleagues and vice versa, and it just doesn't work. I mean, even if you're able to get a cross-network study going forward, our colleagues won't enroll on a study which they don't agree with the approach and the backbone and the study question, and they shouldn't. So I think going forward, we're in a really good place. I mentioned the Hodgkin's and germ cell groups as sort of leading the way, and I think we just need to follow and keep making progress together. And that is the path forward. Expand therapeutic trials, start to develop more AYA supportive care. Survivorship I haven't mentioned yet, but it's wide open. I mean, care delivery for AYA survivors, it's, choose your own adventure. We don't even know what's happening in most sites, and survivorship in many sites isn't even a concept. So lots of work to do there, lots of work for cancer care delivery research, and really just looking to partner with folks to make sure we can ask and answer important questions. I think we're making progress with this health-related quality of life PRO initiative, as well as with the socio-demographic initiative. Looking forward to working across the NCTN to make this the standard of care. And really, I'm just excited about it. I hope my personal Zoom fatigue doesn't sort of, kind of mask the excitement of everything that's going on. There's no better time to be an AYA oncologist and researcher, and to me, these next 5 to 10 years is going to be sort of that golden age of understanding how do we make progress for AYAs, how do we identify the best treatment approaches for these patients, and how do we improve supportive care and long-term health and quality of life. On that note, Becky, I want to thank you for your long-term collaboration and support. I want to thank our funders at the NCI. This has been a great partnership, and happy to take any questions or comments.
Right, I see a comment from Laura Davis that says the sarcoma field has monthly cross-NCTN meeting that is very active with COG, SWOG, Alliance Energy, and ECOG and SARC. Laura, are you able to talk? Do you want to say something about that consortium and the relevance to cross-development of trials in the last year or so since you last presented on this?
Sure. I think there's two folks that have been, Aaron Weiss and Lisa Kopp, have been organizing this cross-NCTN meeting once a month. And it's just been nice to be able to present our concepts fairly early. It's not always early, but it is good to be hearing about some of these concepts actually before they're approved through the even scientific council for each of these groups, so that we can give insight early on. And in fact, some concepts haven't moved on after conversations in the group, but it's also a mechanism for encouraging enrollment across the groups.
Yeah, and I think you guys were one of the most creative groups, because that structure of having a sarcoma committee and each of the different NCTN groups wasn't there. So I really applaud you guys for this effort, because you basically brought together key stakeholders from across the network groups to just figure out how do we identify what are the key questions and also key opportunities to develop trials. So yeah, I'm really excited about the sarcoma efforts, and I think it's a real nice model to, how to get around some of those challenges that Becky, you mentioned before, when it's not clear that, you have these two committees working together. So yeah, really exciting work.
Mm-hmm. Yeah, it is kind of the poster child of a grassroots effort that has involved all of the cooperative groups and not come from the cooperative groups. So it really is cool. And would you talk about, Laura, how you guys use your time in that meeting, in that, there are disease groups that don't yet do this. And so if somebody said, oh, I want to organize a monthly call on my disease of interest for the purposes of AYs, who gets the floor and why and when?
Yeah, so the way that we've kind of organized it is essentially who's interested from each of the groups, right? It's a little bit of, oh, I know this person, how about we invite this person, and try to make it as open as possible, but also not like a free-for-all. I mean, it's generally 10-ish people per month that are there, so just like 2 or 3 from each group, and really just being kind of people who can amplify the message to, bring it back to our respective cooperative groups and talk about it. And it is very informal. So essentially, if somebody has a concept they want to talk about, that it's an open floor. And the way each month it is organized is essentially 1 or 2 people present concepts and get feedback. A lot of times what happens then is we will say, oh, you know what, this concept really needs the input of the radiation committee. And so then we'll all connect that individual to the radiation committee of Alliance and of SWOG and all of the different areas.
That's great. And so I'm assuming that of the 2 or 3 people per NCTN group, you have kind of a mix of more junior and more senior people and a mix of people in different subcommittees within those groups. Is that accurate?
I think that's accurate. I'd say that the majority of participants are medical oncologists and pediatric oncologists. I think there's a couple of folks, well, not regular attendees that are radiation oncologists or surgeons or otherwise. And it is mostly, I think, fairly mid-career folks. So it's not really the super established or the super junior, but we really are trying to make sure that it's inclusive so that we are getting junior folks to be presenting the concepts, right? That's what we really, really want.
Great. And getting back to the PRO conversation, Laura, you may have heard of this initiative through COG as well. What do you think the sarcoma group is likely to do in terms of possible inclusion of PRO battery items in future trials, or is it too early to say?
I mean, I think that I don't know, maybe I'm naive, but all of the trials that I've seen come through in the past 2+ years have absolutely have lots of PROs included.
Yeah, and I'll add the, we mentioned that the piloting within one of the osteosarcoma, the, surgical question of dealing with lung mets. Another concept that's moving forward is a randomized question around cabozantinib, and that also is going to be having or including PRO endpoints. So I've been really excited and impressed and somewhat surprised about how easy it's actually been to get buy-in from each of the groups. I didn't think a year into this initiative we'd already have as many trials interested and just sort of incorporating the battery. And then, for those groups that just learned about it, we presented this at the COG meeting a couple weeks ago, and all of them are like, let's set up, meetings shortly to figure out how we can incorporate them into our concepts moving forward. So I'm waiting for something to be more challenging, but it's been really nice so far.
Awesome. Well, one thing that I can think of, which is, on the to-do list of us for SWOG and probably the other adult groups as well, is how to disseminate this information. Because I know you've gone around COG and spoken to every disease committee yourself. And, we've thought about within SWOG, should we, give a small slide set of things that people could take back to their own home groups. And I know you're supportive of that idea, but I wondered if I wonder what people on the call think about getting this information out about the PRO library to SWOG. What do you think is the best way to share information like this that's relevant to AYAs with SWOG and the larger membership? Would it be from the liaisons from this committee to report back, or is there some alternate way to get the word around?
That would be probably the easiest way for us to involve our liaisons for the different committees.
Yeah.
Because there's already a connection there.
Mm-hmm. Yeah, I think I agree, Lucia. I think that would be super useful. So if any of you guys are planning to attend disease-specific meetings or other sessions that you normally attend and would like to share this information, then please let me or Mike know, and we could get you some information. Mike, where is this PRO library going to live, and how will people access it if they're starting to think about PROs for a design that's still in concept?
Yeah, good question. So, one thing definitely we'll be able to send out, the brief slides as well as the frequently asked questions document. The NCI has agreed to host this information on their side as well, but I'm being very vague intentionally because I don't exactly know what that means. But I think for us, you're right, Becky, the challenge now will be actually dissemination and just making sure everyone's aware of this. I think on the positive side, because all of these trials are being developed cross-network and collaboratively, if at a minimum you have a core group of folks who are aware of this, and most of the PRO folks in each of the NCTN groups are on our committee. So you have folks like Lynn Henry, who leads the SWOG AYA PRO. I'm sorry, the SWOG PRO core. I keep thinking everything is focused around AYA, but that's just my world and not most people's. But I think a lot of the key stakeholders are aware of it or will be aware of it soon. So that will help, and then hopefully it will just catch on that this is standard, but it will eventually live within the NCI websites.
That's perfect. And Hildy Dillon in the chat brings up an interesting comment, very exciting from a patient advocate perspective, to create PRO batteries for patients included that represent a large age range. S1826 has been a perfect example of this in collaboration across the NCTN and adult NCTN group committees and COG. And, I think bringing up patient advocates here is relevant too, because of SWOG's very strong patient advocate presence throughout the disease committee. And so Hildy and other patient advocates on the call, your voice might be a great way to get this information out. And we would welcome that tremendously. So if you would like to share that across the patient advocate committees, that would be really great. All right. Anything else, Mike?
No, really just want to thank you guys. It's been a wonderful collaboration. There's still a lot of work to do, so I think we've made a lot of progress, but honestly, there's so much more that we don't know for this patient population. So just want to thank you guys for your investment and for your time.
Thank you. And take care.
You're muted, Becky.
All right. I was going to share my screen again, but I think that we can just chat because we only have a couple of minutes left. So thank you all for your attention, and the majority of you for hanging in throughout this session. I think we've learned a lot, and I just want to come back to our to-do lists and sort of take-home points from the session. So as you go forward into these next meetings over the next few days, please think about potential collaborations with survivorship, with early therapeutics, with any of the disease committees, and let Lucia and me know your thoughts about that, because you know, there's plenty of internal monies for either retrospective analyses or prospective AYA related trials, and we could you know, collaborate and apply for some of that funding from the Hope Foundation. In addition, there's the SWOG Responsible Investigator Network. Please let me know if you would be willing to be the responsible investigator from your center, or if you know someone who would from your center. I think if we can get the word out, that would be fabulous, and I think that people would find it very valuable and useful as they work to build AYA services in their own institutions. And finally, if you would like to renew your disease liaison status for the AYA committee or become a new AYA liaison, we can do that. And Dr. Blanke has expressed an interest in the method that the COG has been using in recent years, which is to have both a junior investigator and a more senior person for each disease committee, which allows the junior people to you know, to have some say and a role within SWOG. So if you have an interest in that, please let me know, and we will try to make that onboarding process as easy as possible for you. Lucia, any other parting comments?
No, I think that it was great. We had great presentations, a lot of new ideas and concepts that we could develop within SWOG.
Great. All right, thanks everybody, and have a wonderful day. You have 3 minutes before your next session. Take care.
Thank you.
All right. I think we're down to just you and me, Lucia, and hosts. Since we don't have Allison, why don't I just call you real quick by phone?
Okay,
Okay,
that's
I'll
good.
just log out and I'll give you a call right now.
Do you have my phone number?
Let me just make sure I do before we get off. Let's see.